Today's video, we're going over the diagnosis of hip dysplasia. So Nunley et al. In 2011 showed that patients that have hip dysplasia, it took them on average just over 5 years and seen more than 3 healthcare providers to get an accurate diagnosis for hip dysplasia. Now this is obviously a big problem because we need to get an accurate diagnosis to have the best treatments. One of the issues with this pathology is that it presents very similarly to other forms of hip pathology like femoral acetabular impingement. So in today's video, we'll go over accurate diagnosis of hip dysplasia so you don't become part of those statistics. What's up guys, my name is Dan Pope from fitnesspainfree.com. I'm a physical therapist and a strength coach. We've helped to make thousands of incredible coaches and clinicians through online courses, mentoring programs, and communities. The goal of today's video is to make you 1% better. Okay, so what is hip dysplasia? Hip dysplasia is under coverage of the socket. So here's my pelvis. Here's my femur. The socket portion is the acetabulum right here. If I don't have enough coverage of the acetabulum over top of the ball over the course of time, that can lead to problems. So let's say this is my ball and this is my socket. In a normal hip, we have nice over coverage of the socket over the ball. Over the course of time with activities, we have great stability within the hip. If I have under coverage, so let's say I have less coverage of the ball over the socket, over the course of time, that's more motion for the hip to control, more likelihood to have things like wear and tear, hip pathology, so on and so forth. So what are the most common populations to have hip dysplasia? Generally speaking, it's going to be a little more common in females, in sports, or recreationally fit young females as well. Now having dysplasia in childhood is a little bit different than adult dysplasia, but having had developmental dysplasia increases your likelihood of having dysplasia as an adult as well. It's also going to be a little more common in patients that have connective tissue disorders like Ehlers-Danlos syndrome. Next, let's go over clinical presentation, particularly pain. Usually for these folks, pain is deep into the hip. Usually you can't put your fingers on it by palpating the muscles around the hip. Generally speaking, the pain is worse with activity, gets better with rest. And for most folks, the pain is medial, although for some folks, the pain can shoot laterally as well. These patients can also have a sensation of instability, or rather the hip is kind of giving way or the ball is sliding around the socket when it shouldn't be. If you really like loose and floppy hips as much as I do, you should like this video and subscribe to the channel. These patients might also have mechanical symptoms, so things like locking, catching, snapping. And the reason why we think this is that having hip labral pathology is commonly correlated with hip dysplasia. You might be picking up on some of the labral pathology when folks have dysplasia. We also have some good data on initial presentation of patients that have dysplasia from the same article from Nunley et al. In 2011. In this patient, 97% of patients presented with insidious pain, where essentially pain came up slowly over the course of time. 77% of patients had moderate to severe pain on a regular basis. Pain was most commonly localized in the medial side of the joint. That was 72% of patients. However, around 60% also had pain radiating to the lateral side of the joint. 88% of patients had activity-based pain, so essentially it hurt when they did specific activities and actually felt pretty good when they didn't. 48% of patients presented with a limp, with 38% of those patients having a positive Trendelenburg sign. And lastly, 97% of those patients also had a positive failure test, which we'll go over in a second. Okay, next let's go over the objective examination. So like I just said, a lot of these patients are going to present with a limp. And there's a couple of different ways of limps. I'm going to show you a few ways they may present. The first of which is going to be a positive Trendelenburg sign. So essentially when they put weight on the affected side, they'll have hip drop just like so, right? So if they're walking towards you, you might find that hip drops. Whenever they land, take a step, hip drops, okay? The second way that these patients generally limp is, as I call it, an abduction lurch. So essentially when they're on the affected side, they lurch into abduction. Take a step and they lurch into abduction, right? And the last thing you may see is a patient shortening their hip extension range of motion. So if it hurts to fully extend the hip this way, what might happen is when a patient takes a step, as their leg comes through, they lean forward a little bit, right? So it ends up looking a bit like this from the side. They take a step, they lean forward, they take a step, they lean forward. So those are the common ways you'll see your patients limp.
Hey there, do you like floppy hip joints? Of course you don't. Guess who else doesn't like floppy hips? Your patients. So that means you're gonna have to know how to treat hip dysplasia. And I've got the solution for you. It's an evidence-based cheat sheet for the diagnosis and treatment of hip dysplasia. My promise to you is I'll catch you up to date on the latest evidence on hip dysplasia under 10 minutes. And we go over all the most important information, including definitions and background, prevalence and population, relevant anatomy and risk factors, pathogenesis and clinical presentation, physical examination and radiographic findings, injections, differential diagnosis, treatment, physical therapy, surgery, and lastly, return to sport. So this cheat sheet is 100% free. I will leave a link in the description for you to go ahead and download that. Happy learning, and now back to your video.
So these patients often present with hypermobility. One of the ways we can assess this is through a Beighton scale. So we're gonna take Trinity through a Beighton scale right here. The Beighton scale is scored from a 0 to a 9. You have a bunch of different tests throughout the course of the body. Every time you have a positive test, you give yourself 1 point, okay? So the first one is going to be if you have hyperextension greater than 90 degrees at the pinky. Let's see how you do here, Trinity. Oh, does that look positive? What do you think? All right, positive on one side, let's try the other. So 1, that looks positive to me too, right? So you have a 2 out of 9. Next one's going to be, can you touch your thumb to your forearm? Let's give this a shot. Boom, you got a point. Let's try the other side. Got another point, all right. The next one is whether or not you have hyperextension at the elbows. Let's go ahead and see how much range of motion you have there. I don't know, that's close, maybe. I think you got it on this side. So you have another point over here. So let's say we had 2 points at the pinky, 2 points at the thumb, and then 1 point at the elbow. That's 5. That's already a positive Beighton scale. Just looking for 5 out of 9, right? From here, we can also look at the knees. Just have you stand at the side and see if you can hyperextend the knees. Very good. And it looks like you probably have a little bit of hyperextension. Let's turn the other way and just see that one. Yep, and probably have a little bit there too, a couple degrees, right? So 2 more points, already at a 7 out of 9. And the last one is, can we keep the legs straight and palm the floor? We'll see how that one goes. Yep, and great. So essentially, Trinity is hypermobile here. Essentially, we're looking for 5 out of 9 or greater will be positive for hypermobility. So these folks tend to have more range of motion everywhere, but particularly within the hip joint. So we just talked about how there's less coverage of the socket over the ball. And because of this, these patients typically have even more range of motion within the hip joint. So what we're gonna do is go over normative data for the hip, which keep in mind is all over the place depending on the study that you look at. And if your patient is presenting with quite a bit more motion than what we're talking about here, then it may rule in a hip dysplasia that we're talking about. So the first one's going to be hip flexion. Generally speaking, most folks are gonna have around 120 degrees of flexion. So if your patient has a lot more than that, you might start to think they're dealing with some dysplasia. In terms of external rotation range of motion, most folks have around 40. Internal range of motion, most folks have around 30, and hip abduction, most folks have around 40. And lastly, from a hip extension standpoint, most folks have around 10 degrees of extension. So if your patient is beating all these normative values, they have pain in the front of the hip, you might start thinking this seems a little bit like hip dysplasia. So what about strength? Tanning et al. In 2025 showed that patients with hip dysplasia typically have weaker hip flexors. So essentially, we can have the patient seated, and then from here, go ahead and push up nice and strong into me. Good, let's check the other side. Go ahead and push up. And if you're noticing a significant difference in strength side to side, that would be positive. It's also good to use a handheld dynamometer just to see exactly whether or not there is a difference. And then over the course of time, you can check and see if you're making improvements from a treatment perspective. Next, we'll talk about special tests. Unfortunately, we don't have great clinical tests to rule in or rule out hip dysplasia. We can, however, try to use a few special tests to rule in or rule out people having hip labral pathology, but do keep in mind, these are not phenomenal tests to see if your patient actually has hip dysplasia. So we're going over a Faber test as well as a Fade-Ear test. Keep in mind that Nunley study that showed that 97% of patients that had hip dysplasia had a positive Fade-Ear test, right? So we're going to have Trinity lay on her back. I'm going to flex the hip up. We're going to go into maximal hip flexion as well as hip internal rotation. And a positive special test would be a reproduction of the patient's familiar symptoms. For the Faber test, we take the foot and hook it over top of the knee, and from here let the knee relax all the way down to the table. A positive special test would be the reproduction of the patient's familiar symptoms. And lastly, generally speaking, both the Fade-Ear and the Faber are pretty sensitive tests to rule out hip labral pathology, but not super specific to rule it in. So if you have a patient you believe has hip dysplasia, we can begin treatment. However, it's important that if they're not progressing over the course of about 3 months or so, we just make sure we refer back to the doctor to get a more accurate diagnosis. And usually the diagnosis of hip dysplasia is made through imaging, like an X-ray. Okay, so as I mentioned previously, FAI is much more common than hip dysplasia, so it's really important you do a good job diagnosing your patients and make sure they have the right condition. We have a video for you right in the corner. Go ahead and click on that. We'll go over how to diagnose FAI. We'll also go over differential diagnosis in case it's something else.